Good morning, everyone. Let's get onto the right screen. Hold on. Had it all in sync, all nice, and then it messed up at the end. Never mind. Welcome back to a bank holiday Monday Learn Anatomy online. Let's have a look. Oh, we've got a few people here. Obviously, got kids or didn't have enough to drink yesterday, so you're here in the morning at 10 o'clock. Morning, Julie. Got you there. Yeah, got you on the screen this morning. Morning. Hi, Neil. Oh God, yeah, it's been a while. Yeah, good to see you again, mate. Good to see you there. So yeah, if you've not commented before, if you comment in the comments box, then it pops up on my screen, and then I can add the comments onto the screen. So if you've got any questions, then just let us know. And there is a little link on there, an eCam link, and you need to give permission to eCam to be able to use your picture. Otherwise, it looks like this. So good morning, whoever that is. Thank you very much. But like Carol there, we've got your picture. So good morning to you. So if you want to click on that little link, and then I'll know who's making the comments as well and asking the questions. Cool. So yeah, we covered the first part of the wrist and hand last week. We looked at the elbow in the previous week. So the joints around there, and obviously we're looking at the other ends of the bones now. So the main thing that kind of became obvious last week was that the ulna at the elbow is massive, and then at the wrist it's really small, and the radius at the elbow is quite small, and then at the wrist it's quite big. So the bones kind of switch, and that makes sense really with how they move, because we've got the radio ulnar joint and the proximal one, so the one that's closest to your elbow, to allow pronation and supination. But also there's got to be a rotation at the wrist as well. So if you had two bones that were the same size, they wouldn't be able to roll over each other. And we saw that video last week where the radius and ulnar just roll over each other, and that's how we get pronation and supination at the wrist. So yeah, so hopefully that was useful to kind of get that in your head. We also had a look at the carpal rows, and some of you knew the rude versions of the remembering the carpal rows, but we had Sarah likes to play. So the scaphoid on this side was the Sarah, and then the likes is lunate. Two, the triquetrum, which is kind of underneath the pisiform, which is the P, the play. Hey, yay, here you are. It was you. Morning out. Good to see you, mate. Good to see you. And then we had try to catch her as the next row. So we had the proximal row. Sarah likes to play, so that's from the thumb to the little finger, and then try to catch her was the second row, the distal row, and the way to remember these. So it's there are three bones with a T, so it's try to catch her. Yeah. So if you remember in your best Brummie accent, the trapezium is under the thumb, and then the trapezoid is just inside, or trapezoid is just inside. So if you put on a good Brummie accent, then you'll be able to remember those. So trapezium under the thumb, trapezoid just inside, and then so try to catch her. So then the next one is the capitate, and then the next one is the hamate. Okay, so that's those rows. Stevie's here as well. Hey Stevie, we've got the usual suspects in this morning. We're going to have a look if we get chance. Well, we should get chance today at the floor of the carpal tunnel, and understanding the where the bones are in that proximal row will help you then with working out where bits go when we look at the carpal tunnel. There's obviously a lot going on with the wrist, so we've still not even covered the fingers or any of the finger joints yet. So we're going to try and get through most of those and have a look at the floor of the carpal tunnel, and then also hopefully on the dorsum of the wrist, so this part of the wrist. So this is the dorsum and this is the palmar aspect. So the dorsum of the wrist, this bit here, this is where all the extensor muscles are, okay, that come down to extend the wrist. And there's a specific order of your extensor tendons. So we're going to have a look at those when we view that, when we've had a look at the carpal tunnel and when we've had a look at the fingers. So yeah, we'll try and get all that done today. If not, then we'll have to merge some things into next week. Okay, so let's get going. Just get my all right, mate. You're learning, Stevie. Yeah, you teach me the Scottish this colloquialisms, easy to say, and then I'll teach you the Brummy ones. All right, let's have a look at this. We're going to go on to that one. Yeah, so we've had a look at these. This was the recap that we've just done. So Sarah likes triquetrum to play, the pisiform there. So that's your proximal row. That's from the thumb to your little finger. Okay, so scaphoid underneath the thumb. And we had a look at that as well, had its own blood supply. And it's commonly injured bone, especially with fouche injuries, so where you fall on an outstretched hand. So that's a fouche injury. And so you put your hand out to break your fall, and then often break your scaphoid. And it has it, yeah, because it's got its own blood supply. If you disrupt that blood supply, it can't then get blood from anywhere else. So the bone then starts to die. So it's something that we're worried about. It's called avascular necrosis. We had a look at some of the images of what that looks like. And then I mentioned something called Kienbock's disease as well. And again, I forgot to look it up this week, but I'm pretty sure it's the lunate bone, where you can have an issue with the lunate bone. It loses its blood supply, and then it starts to necrose. And so if you're examining someone's wrist, if you're a sports therapist, or even if you're a fitness professional as well, and someone's had wrist pain for a really long time, it's one of those where at the beginning it might hurt, but when they x-ray it or scan it, nothing comes up. And it's because it takes a while for the bone to necrose. So you might need another repeat scan in a few weeks' time, because it's going to be a slow progressive issue. So yeah, if you're still in the back of your mind thinking this doesn't look right, then it's definitely worth sending them through for another investigation. And then distal row, trapezium under the thumb, trapezoid just inside, and then capitate. So anything with cap is like, remember, like baseball cap, it's shaped like a head. Okay, so it's kind of like dome shaped. And then you've got the hamate, and there is a specific part of the hamate, this little bit here, which is a little hook. And you can sometimes, it depends on how meaty your hand is, but you can sometimes feel the hook. You have to kind of dig in quite hard. You've got the pisiform bone, which is usually quite easy to find, that bit there. And then the hamate, you come towards the little finger and then medially, and it's usually around there. You have to have a good old root around. If you've got quite chunky hypothenia eminences, which is this bit here, then it's going to be a little bit more difficult to feel. It's an important bit when we get to the nerves. Okay, so that give you a bit of a clue when we as we progress along. That we had a look at. That we did. This was the scaphoid stuff and the blood supply and the avascular necrosis. And here we are. Okay, so this is where we got up to. So we started to have a look at the wanted to start to have a look at the metacarpals now. So we've had a look at those carpals, which are these bones all in here. And whenever you study this area, it's they're only really small, and on the pictures they look as if they should be a lot bigger. Okay, so and these metacarpals. So these ones just here. Okay, these are your metacarpals. These extend from that carpal row all the way up to this point here. Okay, so that joint there. So all of that, all of your palm basically is metacarpal bone. Okay, so that's all. Obviously, there's tissue, and we'll add the tissue layers on as we go. So there are 5 bones, obviously, for your 5 fingers, and they make up the palm of the hand. Have a look at these in a second. Numbered from 1 to 5, from lateral to medial. And the first is the most mobile. So obviously your thumb. One of the reasons we can do many of the things that we can do with our hands is because of our opposable thumbs. So we've got and we'll have a look at the reason for that as well, because there's an anatomical reason why we have that mobility in the thumb, but we don't have them so much in the joints of the fingers. Okay, so the joints we're looking at there between the carpal rows and the metacarpals are the carpo-metacarpal joints. Okay, so this is why knowing the names of the bones is really useful as we go into the joint names, because the joint names are massive and you think, what the heck is that? But if you break it down, the carpo-metacarpal joints make sense. Okay, so we've got carpal rows and then metacarpals. Thank you. Thanks, Al. It was the lunate. Thank you. I thought it was. Yeah, so Kienbock's disease, also known as lunatomalacia. There you go. I think that's how you pronounce it. Idiopathic avascular necrosis of the lunate bone. Yeah, so avascular means without blood, and then necrosis means death. So yeah, if it's one of those ones where someone's wrist just isn't getting any better, and you've done loads of work on it, you've done some strengthening work on it, and it just doesn't seem right, then it's worth getting that checked out. Thank you, Al. If anybody who hasn't met Al before, Al is one of our tutors on the movement therapy diploma up in the northwest, up in the Liverpool area. So yeah, well worth having a look at his clinic. It's called, I love the name of it. It's Clinic Al. You had the perfect name for that clinic, mate. And yeah, he's posting some really good stuff up there, so worth following Al. So, and thank you for that, mate. Yeah, if ever I have something like that again, you can jump in again, mate. Thank you. So each of the metacarpals consists of a base. So the base of the structure, so nearest to the body, shaft, and the head at the distal end of the bone, so furthest away. And then those metacarpals, when they come distally, they then form the bottom part of the knuckles. Okay, so the metacarpal from the carpal rows up to the knuckles. Okay, so that's the area that we're looking at the moment. Cool. Okay, let's just have a look at some of these. So let's have a look at some of these. Here we go. So these are the carpal rows that we've had a look at already. These are the metacarpals, so we were just looking at those. And then these are your phalanges. Let me just pause that there. So the phalanges in the fingers are very similar to the phalanges in the feet, because in your fingers, in the second, third, fourth, and fifth digits, you have 3 bones. So you have a proximal, a middle, and then a distal phalanx. Okay, so proximal, closest towards you, middle, obviously in between, and then distal, furthest away. Okay, and that's the same in the foot. Okay, so when you have a look at the phalanges of the toes, so these are all long bones, because a long bone is described as something that is longer than it is wide. So even this one here, even though it's tiny on the end of your finger, it is longer than it is wide. So that is considered a long bone. Okay, so these phalanges are long bones. And then if we just play that again there, and you'll see in the thumb, there's only 2. Just pause that there. So this bit here, that's your metacarpal. And then you have a proximal phalanx and a distal one. So we've only got 2 bones in the thumb, whereas we've got 3 in each of the other fingers. And that's the same with the foot. Okay, so in the big toe, there's only 2 phalanges, and then in the rest of the toes there are 3. The thumb, we mentioned this last week, is called the pollux, Pollux, pollux. So this is important because when we have a look at the muscles, some of the muscles are called pellucis. So anything with pellucis in means it moves the thumb, basically. Okay, so we'll have a look out for those as we go through. Let's just play that. Here we go. Okay, and then obviously we've got the joints. So if I just pause that there, so let's have a look. So this is a metacarpal. These are your carpal rows. So these are this joint line here, all across there, is your carpo-metacarpal joint, okay, because it joins the carpals to the metacarpals. So that hopefully will make sense to you. And then the next row, I'll just pop that there. So that's your metacarpal, and that's your phalange. So these are your metacarpo-phalangeal joints. Okay? And again, if you look at that word and you've never really known what the bones are called before, then it can be quite confusing. But we've got metacarpo-phalangeal joints, and these are your knuckles. So if you make a fist, that joint line there, that row, that's your MCP joints, so your metacarpophalangeal joints. Right, just play that again. I'm going to go up a little bit further. Okay, these are your interphalangeal joints because they're in between the phalanges, and because in the fingers we have a proximal and a distal row, yeah, because we've got 3 bones, so we've got a join in between. So there's your metacarpal, so that's your MCP joint. There's your phalange, so proximal, middle and distal. So we've got joints in between here, in between the proximal and middle, and then distal and middle. Okay, so we've got joints all in there. So these are called, so this distal interphalangeal joint is shortened to a DIP, a DIP, often. And then this proximal row, so this joint here is called a PIP, PIP. Okay, so you might see in notes that we've got PIPs and DIPs and MCPs and CMCs. Those are all the joints in the hand. So carpo, metacarpal, metacarpal phalangeal, MCP, and then you've got pips, proximal interphalangeal joints, and then dips, distal interphalangeal joints. Okay, so with the hand, it's just one of those that you just got to keep on going over and over and over. See, I love this kind of thing because it's really difficult, and you have to just go over it again and again and again to get it into your head. Okay, and there is no real easy way of learning it. I find when I got fairly good at teaching anatomy, that's when my understanding of anatomy got better. So if you can teach people this stuff, whether it's your kids or your other half if they're interested, or your patients, obviously, then once you can start articulating all these things and starting to explain them to people, that's when you know that your knowledge is really good. So when you can explain it simply, it means you know it really well. So that's probably the best way to learn, is to try and teach other people. Okay. Let's have a look, see if there's anything else on here. I think they shorten them to IPS and MP joint. Yeah, so we usually call that MPC joints, MCP joints, metacarpal phalangeal. These are usually pips and dips rather than just IP joints. Okay, so pips, proximal, dips, distal, MCP, metacarpal phalangeal joints, CMC, carpo carpal joints. Got there, right. So those are all the joints in the hand and the wrist. but then you've also got these joints in between each of the carpals as well. So let's just have a look at that. Just get onto these. Done those, done those, done those. Yeah, here we go. Okay, so they aren't easy to distinguish, and if anybody had anything wrong with them, then as a manual therapist, you just wouldn't be able to tell. They're all so close together. You could have an eye. What I would tend to do is split the wrist into segments, so like a lateral portion and a medial portion, and a distal and proximal area. So if there was an issue with one of the joint lines, then you would say proximal joint line or distal joint line, because it is really difficult to be able to palpate these specific bones. It's nigh on impossible. So we've got these joints up here. So distal radio ulnar joint. Okay, so we had a look at that last week. We've got a radiocarpal joint, so around here, and then you've got the carpometacarpal joints, which we just had a look at, and then intercarpal joints. So these are the ones that we haven't looked at. But basically, between every single one of your carpal bones, there will be a joint space, and it will be filled with synovial fluid. Okay, so all of these are all surrounded by capsules and synovial fluid. Okay, but they're not given specific names. Okay, so it's just intercarpal joints. That's all, especially in manual therapy, physiotherapy. That's all we would need to do, unless you specialise in the hand. If you become a hand physio. So let's have a look at this. Just pop that together. Going to have a look at the floor. Here we go. Okay, so this is the floor of the carpal tunnel. So we're starting to see how the structures of the wrist affect some of the conditions that you might get around the wrist as well. So let's have a look at this. I think I've labelled this one up, hopefully. So that is a view of a right hand. Yeah, there we go. Let me just move me out the way up there. So if you pop your right hand out in front of you, then hopefully this will make things make a little bit more sense. So pop it out there. So we've got the thumb over here. Okay, so that's the thumb. That's the trapezium just there. There's the scaphoid just there. That bone there, that pea-sized bone there, is the pisiform. And then just under that is the triquetrum. And can you see that one there? So that's the hook of the hamate. So we were talking about that before. So if you can palpate that pisiform bone just there, and if you have a look at it, it's towards the little finger, but then medially. Okay, so just on the inside of that palm. And if you've got fairly, like I say, not really meaty wrists, then you might be able to feel that hook of that hamate if you're digging around there. Okay, and it can be quite sensitive in and around that area. So we've got that hook of that hamate and the pisiform. Let's just have a look at the rest. Yeah, so there's the hook of the hamate. That's your tubercle of the scaphoid. So that's your scaphoid there, and there's a little lump on there, and that's really important because the pisiform and the hook of the hamate, they've got this. There's a piece of fascia that connects over those, and when we get onto the nerves, you'll see the importance of that and the space that's available for the carpal tunnel. Okay, so because the roof of the carpal tunnel connects the medial and lateral sides together, and then all the structures then go underneath it. Okay, and one of the things that piece of fascia connects to is this tubercle of the scaphoid. Let's just have a, and there is a little crest on the trapezium as well. And if you have a look at it there, that is the carpal tunnel. Okay, so this is the floor just here, and you've probably heard of the carpal tunnel and carpal tunnel syndrome before. And as we start adding the structures in, so here, this is where all of the muscles that flex your fingers will pass through this region with that piece of fascia over the top, forming that roof. And then underneath, in that tunnel, is your median nerve as well, and we'll have a look at that as we go through. So this is what it looks like with everything removed. So these are all the ligaments of the palm. There's the floor of the carpal tunnel. These are the sides. So you can see the scaphoid, the trapezium, pisiform, hook of the hamate, and there it is there. Okay, so there's just another bit of tissue that connects over the top that forms the roof, but this is all of the undersurface of that carpal tunnel. So you can see that if there's, with the roof on, if there's any kind of swelling or anything like that around the wrist area, then whatever's in that tunnel can get compressed, and that's why sometimes we have the issues, or see the issues that we do. Cool, so I just wanted to show you that. Let's just have a look at these, just see if there's anything else in here. Yeah, we've talked about those. Yeah, and those. We talked about those and those already. Yeah, cool. So this is a nice picture just to wrap up the finger, and then we'll have a look at the finger in a bit more detail. Start adding the ligamentous layers on as well. So this is one of your fingers. So here we have the MCP joint. Okay, so this is your metacarpal, and that's your proximal phalange. So that is your MCP. This is the PIP, proximal interphalangeal joint, because it's in between the phalanges, and then there's your dip right at the end. Okay, so that join in there. There was, mate. Yeah, it was really good. So if you're new to the group, we arrange trips over to Keele University, and hopefully soon over to King's College London, where we show you real anatomy. So if you live in the UK and you can make it, then we've got some real life anatomy that we can show you. Okay, so we arrange trips to those labs. Right, let me just show you this one. Here we go. Okay, so these are the ligaments of the wrist and the hand. There are some that are really obvious, and then there are some that are just really broad, just kind of where you've just seen on that picture, that they all just kind of merge into one. Okay, so some of them you can be quite specific with, some of them you can't. So if we have a look at these, we've got palmar ligaments. So these are ones on the palm, just in here. So we've got and they're named after where they attach. So we've got palmar radiocarpal ligaments. So these go from the radius on into the carpals, and you can see it's just a mishmash of tissue. Yeah, there's no clear sections of these ligaments. They may be thickenings of fascia, but they all just kind of merge into one. And then the palmar ulnocarpal ligaments as well. So again, we've got going from the ulna into the palm. All right, so they form the floor of the carpal tunnel, which is what we've just seen. All right, so so that's those ones. Then we've got, hopefully, if it goes, yeah, collateral ligaments. Now these ones you can kind of palpate. So where these go, let me just move me out of the way. These can quite often get injured with well, in sports, falling on outstretched hand, those kind of things. So that these are quite common to get injured. But you've got they're called collateral ligaments, and we've already seen collateral ligaments in the knee. We've seen them in the elbow. We've also got them in the wrist. Okay, so this is why if we use the term collateral ligament, we need to be specific with where they are. So, which is what I need to do on this actually. So we've got ulnar collateral ligament. Now that could be up in the elbow, yeah, because we've got an ulnar collateral ligament there as well. And then we've got radial collateral ligament in the wrist, but we've also got one in the elbow as well. So really, that should be distal ulnar collateral ligament. So if you're writing notes, if you want to be more specific, then we've got distal collateral ulnar collateral ligament. So the UCL in the wrist, so the distal portion, provides medial support from the ulnar styloid process. So remember we found those last time. So the styloid is that bony projection on the end of your ulnar bone, so right in there, that bit there, and then onto the triquetrum, which we know is just underneath the pisiform. So the pisiform just there, triquetrum is just around it. So in between there and there, that's where my ulnar collateral ligament will be. So because it provides support for the wrist to stop it from deviating. Okay, so if you ulnar deviate the wrist, so go that way, that's going to slacken that ligament. So if you then feel in that space and then radially deviate the wrist, you will feel, you won't be able to specifically feel the ligament, but what you'll feel is tension created in that area, which is the ligament stretching. Okay, so that we know then that ligament is intact because we're getting that firmness in that area. If there was an injury to that ligament, then there would be no firmness. It would just keep on going because that it's not holding it together. Okay, so that's one of the ways that we stress test ligaments. And then the radial side, so radial collateral ligament for lateral support goes from the radial styloid. So it's a little bit less bumpy, that one, but that's the end of your radius bone, and that on the thumb side, and that goes to your scaphoid, which we know then is the next bone up. So just in that space there. So as you ulnar deviate, so take the little finger towards the ulnar, that will then stretch that radial collateral ligament. So again, you can't really palpate the ligament, but what you can palpate is the tensioning of the structures in that region. Okay, so that's where those ligaments are. So they help provide medial and lateral stability of the wrist. Okay, so that's those ones. And then this one is probably one of the ones that if you've never heard of it before, this gets injured a lot. And if you're going for an examination on the wrist and you've got problems on that ulnar side, it may be the TFCC that is causing the issues. So what it is it's a combination of a bit of tendon sheath and a bit of ligament. So it's called the triangular fibrocartilage complex. So it's a mixture of all different structures on this little finger side that stabilizes that part of the wrist. Okay, so again, if you fall and open up, so go into radial deviation, then you'll open up all of those ligaments on that side. So it's formed of the distal radial ulnar ligaments. Okay, the UCL, which is the ulnar collateral ligament, which is what we've just seen, the ECU, which is the extensor carpi ulnaris. We'll have a look at that in a bit. Sorry about all these little acronyms. And then the ulnar carpal ligaments, which we saw before. So it's a combination of all of those structures that provide this control of the radius. And we saw that when we were looking at that pronation supination video last week. Okay, so it's one of the areas that you can image on ultrasound scanning. Okay, so and you can see if the structures are still intact. So if someone's gone over on their wrist and they're really sore on that ulnar side, then it may be a TFCC injury, and there are specific tests that you can do to have a look at that. Right, let's have a look at some of those. So let's go back to the joints. So we're going to have a look at the joint lines a sec. Here we go. Okay, so these are the CMC joints, so the carpo-metacarpal joints. So if I just pause that there a second. Okay, so just to orientate you again, just move me over there. So there's your thumb. So if it's helpful, then put your right hand out in front of you so that you can view the screen and then view your right hand at the same time. So that's your thumb. Trapezium is under the thumb. Trapezoid is just inside. So that must be your thumb. That's the trapezium. That's the trapezoid. And then, so that's try to catch her. Okay, so this one here in the middle is your capitate. And then H is your hamate. And you can see the hook of the hamate just there. So we're looking at this joint line just here. Now, remember when we were talking about the movements available in and the thumb has got this opposition movement, is able to move a lot more freely than the other fingers. This is why. Okay, so the trapezium is shaped in such a way that the thumb, the concave surface of the thumb, so it's kind of curved inwards, and then the convex surface of the trapezium means it can glide in all different directions, and that's why we've got all of that range of motion in that thumb available, because of that joint there. Okay, these ones are really compacted together, so you don't actually get much movement at all. You get a little bit of movement from that one, but not very much at all from these last 3 digits at this joint. Okay, so it's the carpo-metacarpal joint, so it's right down here in that. So just after the distal row of carpals, we're looking at these joints all along here. Okay, so let's have a look. Yeah, so that's thumb, obviously first finger, second finger, third finger, fourth finger. Yeah, hold on. Wonder if yeah, thumb first, second, third, fourth, fifth digit. Confused myself then. I was like, why have they only got 4 fingers? Okay, let's have a look at this. So you can see the hook of the hamate articulates with your little finger and your ring finger. Okay, so they both share an articulation with that joint. If you remember from last week, I said one of the ways that you can find the capitate is by following down the middle finger, okay, all the way down the metacarpal, all the way to the end, and then you'll feel the capitate bone. And that's why, is because the only bone that the third metacarpal articulates with is the capitate. So you know that it's the capitate you're on if you follow that all the way down right to the end of that bone. You feel the bony part at the end, give it a bit of a wiggle and you can feel the joint line, and then you know the next bone that you're touching has to be the capitate because it doesn't articulate with anything else. So this is where knowing the anatomy can help you orientate around the wrist quite nicely. Let's have a look. Okay, so you can see that shape of the trapezium. You'll get to see this in a second here. So this is with a lot of the fascia still intact. So you get a little bit of movement from the little finger, a little bit from the fourth, hardly anything from the second and third. Okay, so very little movement from those joints, CMC joints in that second, third finger. Okay, a little bit more at the little finger and ring finger. Let me just pause that there. Okay, now this bit, so if you get your right hand again, this bit is this. Okay, so the inside of your knuckles, okay, so on the palmar surface of your knuckles, we've got this row of a ligament, and it's called the deep transverse metacarpal ligament. So it runs all the way along there, okay, but obviously doesn't attach to your thumb. So this is another reason why we've got this freely movable thumb, because of the shape of the joint, and also there isn't a ligamentous attachment to the rest of the hand, whereas with all the other fingers there is. Yeah, so all of these are joined together by that ligament just there, right? And you, what you'll see as we go through, so see these gaps here, that's where your tendons will go. So you'll see that as we add on the muscle layers. So it's a really, really strong ligament that connects all of your fingers in the palm. But it obviously doesn't attach onto your thumb. So that's why that can wiggle about. Okay, so that's your CMC joints. Let's have a look at this one. Just get rid of that. Here we go. So we're going to have a look at the fingers. Now there's something specific with the fingers. Where are we at with time? Okay, so where if you put your fingers like this, you can if I try and hold my everything still, you can deviate your fingers medially and laterally from these MCP joints. Okay, so you can wiggle them side to side, and they're pretty freely movable in that direction when the hand is flat. But if you bend the fingers and then try and do it, you won't be able to do it, and you've got to find out why now. So let's have a look, unless you've got an injury, and then you'll be able to do it. So we've got proximal phalanx, middle phalanx, distal phalanx. So we've had a look at those already. So this is your fingertip. So this is where your nail would attach on your finger. So we're looking at the metacarpal phalangeal joint. So this is your knuckles, right? And the end of the metacarpal is dome shaped. So we can have a look at that. So we've got that metacarpal head. So that's your knuckle. That's your knuckle part. And that's why when your phalanx attaches to it, it can glide all around it because the phalanx is concave. There you go. You can have a look there. So that's the base of the phalanx. So that can glide all around the place. Here you go. So these are the kind of movements that you can get from these joints, and you can get side to side. I mean, he does that really well. I don't know how he does that. I can do individual ones, but I can't do the whole lot. But when you bend the fingers forward and try to do the same, you won't be able to do it. Right. So if we have a look at why, so the MCP, so the knuckle joints have got a really thick capsule. So it's very similar to the shoulder joint and the hip joint. We've got that synovial capsule. And on this side, we've got this palmar plate, which is a really, really thick piece of fascia. So it means that you can flex the finger, but it won't extend. Look how thick it is. Okay, that's the thickness of the fascia that's on the front, the palmar surface of your finger. So it limits extension. You can't extend your fingers because of that palmar plate. And the other thing we've got, collateral ligaments again. So these are ones on the outside of the fingers of the MCP joints. And again, these are really, really thick ligaments. So when the fingers are straight, when they're extended, the ligaments are lax. So you can have a look now, it's quite lax. But then as soon as you flex, the ligaments tighten up. And that's why when the fingers are extended, you can wiggle your fingers around. So if you hold that right there, but then when they're flexed, you can't move them. Okay, they tend to move from the CMC joints instead. Okay, cool. Right. We've nearly finished the basics of the hand and the ligaments. Okay, I think we're going to have to do another session of these as well, just to finish them all off. There is so much in the wrist and the hand. It's one of those that, like I said before, it takes a long time to get your head around. So if anybody's got any questions throughout the week about the hand and the wrist, some of the conditions that you get, I wanted to have a look at the dorsum of the wrist, but we're going to have to leave that for next week because there's still quite a bit before we get to that. But we'll have a look at things like de Quervain's veins, tenosynovitis. If you've not heard of that before, then we'll do a little, especially if you're a lot of manual therapists on this. Most people have some irritation of those tendons, so we can do a little test for you to have a look, see if you've got any symptoms. Most therapists usually have, and yeah, and we'll have a look at all the. We'll start having a look at the extensors first of all, coming down into the fingers, and where they travel through, and then where they attach into the hand. Yeah, we've nearly done the basics of the kind of really deep structures. We're going to start to add on those layers now. Cool. Enjoy the rest of your bank holiday. And like I say, if you've got any questions during the week, then just pop them into the group, and happy to answer those. Thank you, Al, for your help with finding the Kindbox information. So Physiopedia is usually a really good resource for that kind of stuff. And yeah, we'll see you next Monday, 10 o'clock. Cheers, guys.